Well, welcome everyone to this week's Crisis Jam. I'm David Covington, your host for today, and we're really excited to have Dr. Mark Ragins with us. We're going to get to his featured presentation in a moment, but you're actually looking at a picture of the Village, the Mental Health America inspiration for a lot of recovery work. That was, Dr. Ragins, you were just sharing, you led the team there from 1990 until 2017. And several of us on this call were part of the Phoenix area mental health leadership at the time. We had 23 outpatient clinics that were dedicated to individuals with serious mental illness. And at in the mid 2000s, they were really characterized not just by intrusive sort of interventions, but it felt more like a forensic setting, plexiglass between the guests and the staff, security keypads, separate restrooms, and a lot of they weren't welcoming facilities. They were small, they were dark. And I was part of the team. We visited the Village in 2009 or 2010. Dr. Ragins, I remember one of the things is, we were challenged walking in, could I ascertain who was staff and who were guests? And it was really just a remarkable sort of environment. And if we can go to the next slide, Karen, this was one of the transformed clinics in Phoenix. This was, I think the organization is now Copa Health. That's the, at the time, CEO Christy Dye and the medical director, Greg Gale, but they created a facility, and there's not only not a locked door, but almost not a door, the whole facility. And this was early on before they got the tables in. So it really landed up looking more and feeling more like a community Starbucks than it did what those unwelcoming facilities of the past, and really inspired by your work. So looking forward to your featured presentation here in a moment. But to start, Harvey Rosenthal, are you with us?
Karen, yes, I am, David. If that's you, David, yes, I am here.
Yeah, welcome, Harvey. Thank you. I saw your email about the passing of Darby Penny, and Lisa St. George on our team was talking about her contributions, and I thought it would be great for you to spend a minute just reflecting on her life, her advocacy, and her contributions.
Well, it's very kind of you to ask, and very meaningful. I appreciate it. And I'd love everybody to hear a little bit about Darby. Darby Penny is a real hero. Are you able to see me on the camera, by the way?
We don't. We see your picture.
Well, here I am, right?
There you are.
I'm sorry again for holding us up. I know you're on a tight schedule. So Darby Penny is really one of our great heroes, and maybe not known to enough people. And I'll bet those people that knew her as somebody who was fierce and relentless and a truth teller. And it wasn't always pretty. And, I don't know that she won a lot of friends when she worked as the first director of recipient affairs at OMH, or even was an advocate in our community, but the outpouring all over the place of love and respect, I think she'd really be surprised, quite honored. She was someone who was the first director at recipient affairs. And in that way, she really constantly brought the issues of peer support and rights and recovery to the table. Well, that was a big lift, and even at OMH in those days. And she often was marginalized, and it was painful. She was courageous. She kept going back. It was not easy to be courageous in those days. It's not easy now. But in that job as recipient affairs, she created the first state-funded, state item here in New York on peer specialists. But she grew to regret that, because, and I know we all talk about this, David, you and I and others, Lisa, that the fear she had that peer services would be co-opted and reduced to, well, let's ask the peer to take them to the doctor, has happened. So I think, were she here, she was still always really critical. I always say she sits on my left shoulder, was always, cranky and telling me it wasn't enough, it wasn't right, and I'm grateful for that. I would always say, what would Darby think? It causes me to, we're negotiating contracts, and it causes me to hold very firm for the ethics of peer support and not just willy-nilly hand out something and everybody says they're doing the NIAPR's Bridger program. So she really leaves behind a grieving, shocked community, more than she would have ever have dreamt. And any of us that really were touched by her, really feel the loss. She, we all say, her body may be gone, but we hope that she gets how much love and gratitude and rest in power. I will say last thing is David, I think, has on the screen here a picture of maybe the cover of a book, I'm not sure. One of Darby's great, most compelling contributions is she went to Willard State Psych Center in New York and found all these suitcases. It became known as the Suitcase Project. And what she did was humanize people who had lived their lives there. And she found out details about them. And they were the forgotten people who were buried in unmarked graves and who felt they would never recover and never would be given choice. And that was a real fitting, sort of example of her work. And anybody, if you can read the book or go online, she was standing up for people all the way through, particularly back in the days where people had no rights or were given any hope. And all they were was a name on a grave or, a suitcase in a room and not really a full person. So, we all mourn Darby Penny, and I hope in this call and in all our work, we just always say, to the best of your ability, what would Darby say?
Darby, thank you so much. I didn't think I knew Darby when I saw your email, and then Lisa referenced this Suitcase Project. I did see the installment, had an hour at SAMHSA one day and went through the entire thing, and it was so powerful. So thank you so much, Harvey, for lifting up Darby and her, not just advocacy, but activism and vision and mission. Thank you.
Well, thank you for asking me, David. I'll let you go.
Thank you, Harvey. So let's go to, I believe, Karen, we have the just the ongoing updated map of our engagement. Again, if you're with a Medicaid authority or you're a national organization that's not reflected here, please let us know. We are continuously providing the videos and presentations from these crisis jams on the talk.crisisnow.com. You can share the link, jump into the meetings, get the reminders, or view the videos. So appreciate your sharing that information and helping us grow this learning community. Next slide, Karen. So for today's quote, I want to hearken back to a conversation that went on during the Crisis Jam back a few months ago now. We were talking about the SAMHSA guidelines for behavioral health crisis care, and in particular, we had shifted from mobile and facilities to the discussion of call centers. The guidelines suggest that the staffing of 988 and Lifeline is underneath the supervision of clinical professionals, but it doesn't speak specifically to the credentialing requirements of the people who answer texts, chats, calls. And so someone on the call asked Dr. John Draper, what does Lifeline expect? And his answer was, Karen, trained, competent, and caring. So there isn't a credential or educational background requirement. And this really opens up the opportunity for the engagement of peer supports to build on Harvey's and Darby's work early on. Trained, competent, and caring. And that sets the stage for our featured presentation today. Dr. Ragins, we're so glad you're with us and love the title, Focusing on Recovery, not even in crisis, but especially in crisis. So Dr. Ragins, tell us about your reflections on this really important juncture of 988 and extended crisis care up against these principles of recovery and peer supports and more.
I can share screen. Thank you so much for having me. Well, I'm trying to get this. Wait, I can't.
So we'll show the slides for you, Dr. Ragins. We've got it set up.
Okay. Go to the first slide then. Oh, look how fancy too. All right, so I'm part of California's giant effort for the Mental Health Service Act, which brought a couple $2 billion to mental health services and designed to be recovery oriented. And we devoted a great deal of that money to our version of ACT teams, to full service partnerships, to wellness centers, to peer run services, to supported housing resources, but it did not substantially impact crisis services. And this is a great loss because in fact, crises are where the seeds of recovery usually happen. These are the times when people make the decisions to make changes in their lives, to stop drugs, to take pills, to bring their family around them, to get off the streets, to change what they're doing in their lifetimes, when they're looking for meaning for that voice of God that they're hearing in a way to integrate this into their lives. It's in crisis that the most important recovery things happen, and yet we were not able to make recovery programs integrated into what crisis was doing. And I think there's two big reasons for that. One is because the politicians who push crisis recovery are almost entirely fear-based. They want these crisis programs to make sure no crazy person shoots up a bunch of people and creates a mass murder in their county. That's their number one goal, by far. Also, the people who run the crisis programs themselves tend to be heavily medical model or police or both, and heavily into safety first and risk reduction and not thinking about recovery. Their model is, first you handle the illness, first you get things stabilized, first you get the dangerous down, safety first, then we can worry about recovery. And by doing that, they're destroying a great deal of the possibilities of recovery that would happen in that time. When you address people with a bunch of coercion, a bunch of sedation, a bunch of handcuffs, you're making it harder to recover. And they say, well, we'll deal with that later. Well, a lot of damage has already been done. One of the most painful professional experiences in my life was my residency experience working in the ER at LA County USC. It's a very overcrowded place. The police would bring in people, tons of violence. At the time, lots of PCP psychosis, lots of mania psychosis. People would stay there for days trying to find a bed to go to. But that's not the most painful memory I have of that time. Most painful memory is a lady who came in who had just been raped 2 days before. And she was terribly traumatized. She was shaking and shuddering. She had tried to kill herself. She was so overwhelmed. And here she comes to the hospital. And what I'm going to do with her is put her in a large holding room where people come and go, who are tied down, yelling and screaming. And this is supposed to somehow begin her process of healing. And I told the supervisor, you know, we're no longer really even a hospital here. We're just kind of an extension of the jail, taking care of people that they can't handle over all the police that's bringing us people. The supervisor, I said, well, I like to look at it the other way around, that the police are outreach workers and go and find people in need and bring them to us for treatment. Now, there's some truth to both those points of view. And indeed, we've improved on both those points of view. There's now substantially more mental health treatment within our jail at LA. And there's also substantial improvement in police outreach. There's lots of police training about mental illnesses. We do these shared teams with one policeman and one mental health worker. We do these community-based policing things where they don't bring people to either jail or the hospital. They help them get a hotel voucher, do a detox, or do our homeless outreach program or something in the community. But this program is the first real strong opportunity to actually replace the police going out there being outreach workers and us becoming our own outreach workers, our own engagement workers. And when we go out there, all right, we'll leave the badges and the guns behind, but what are we going to bring with us instead? If we just bring with us instead the same old safety first, risk management, liability reduction, restraints, medications, points of view, we will have wasted this opportunity and the possibility for recovery for thousands and thousands of people. What else can we bring when we to these crises when we leave behind the badges and the guns? Maybe we could bring, like a friend of mine, Wayne Munchell, brought to see a man with schizophrenia who was stuck in his bedroom, wouldn't come out and do anything. He brought his guitar along to the outreach. Maybe like I brought to a hotel room at Skid Row of a terribly paranoid woman who terribly did not want to go to a hospital and was too paranoid to leave her room. I brought a needle in my pocket to give her a long-acting injection there. Maybe it's like Dr. Helen brings food every time she does an outreach call to be a maternal caring, or Cherokee, when he does homeless outreach, brings food as part of breaking bread and connecting with people. We have a lot of wonderful recovery things we can bring along, everything from peer support to meaning making, to hearing voices, to motivational interviewing and harm reduction, to soteria models, to family reunifications, to open dialogue, to shared decision-making, to empowerment, to person-centered medications, to building resilience and protective factors. There's so many things we can bring in our package along. And if we stick to, well, we're just going to do dangerousness assessments, avoid liability, do involuntary treatment. I'm sorry, if there's nothing dangerous happening here, there's nothing we can do. We will not be fulfilling the promise of this program. Next slide, please. So to actually do things in a recovery way, it takes three major transformations. The first transformation is from illness-centered to person-centered. That's because most crises are not crises of the illness. They're crises of the person's life, things that happen to them. One of my first suicides was an inpatient who was this 64-year-old guy. He was a draftsman, but that was becoming already replaced by computers. And he was burned out on life, didn't like his wife at all. And so on weekends, he would go to Hollywood, hang out with prostitutes, and smoke PCP. By the way, when I was in my 20s, that was entirely inconceivable to me. Now that I'm in my 60s and I've been through the isolation of a pandemic, I'm not saying I'm in that situation or I would do that, but it's not inconceivable to me anymore. I can see how you'd end up in that spot. When I saw him in the hospital, I took care of the PCP psychosis, got him back to himself within a few days. Didn't need any follow-up care except to be told, don't use any more PCP. 3 months later, I got a call from police because my business card was in his pocket. He had killed himself by fixing himself in his garage. As he had warned me, the boss had fired him right before he turned 65, so he didn't have to have a pension, and he was stuck with a life and no money and no going nowhere. I hadn't paid any attention to that because I was so busy treating his illness, a PCP psychosis, and I didn't help him at all in that time right before the crisis got terribly violent in the few months before, to do something preventative to help him reinvent his life, turn around, to find some hope or openings. I treated an illness and didn't see the life at all. And most crises are problems in life, not problems in illnesses. Second transformation is from professionally driven to client-driven collaboration. This isn't just a question of avoiding coercion and avoiding doing things to people instead of with people. Although certainly recovery is not something you do to someone. It's something you empower them to do in their own lives for themselves. And they're not gonna do things that we do coercively. That's not how you talk anybody into doing anything. But this is about seeing things from their point of view, from conceiving of what their life is like. A man walked to my office late one afternoon. He holds up his hand like this. He says, "What do you see?" I said, "I see your hand." He says, no, be more specific. I said, "All right, I see the swirls of your fingerprints. Everyone's different. I see the creases between your knuckles, and I see your love line and your lifeline. I don't know which one's which, but I can see them." He says, when you can start to see nails and knuckles and hair, you will be able to start helping me because you'll be seeing the world from my side instead of from yours. Recovery is on their side. There's a difference between making a service plan for a misunderstood prophet of God and for a non-compliant, manipulative, duly diagnosed patient. We need to see things from their side, what's going on from their point of view, to even bring in something like harm reduction, or to bring in something like trauma-informed. Third transformation is from deficit-based to strengths-based. There's many places who do the first two who don't get this third one, who still try to help people by fixing what's wrong with them rather than building what's right with them. I had a man who for a year, he would call suicidal every night on the crisis line. They'd say, "We have to hospitalize him." I said, "Don't hospitalize him." I spent time with him, drove my wife crazy over and over and over again. Finally, he decided to kill himself. He took a bunch of pills and actually did it, and then realized he didn't want to die. He had a relationship with us, so he called us. We sent out the ambulance, saved his life, and he said, if I got that desperate, I need to do something to change my life. He came out as gay to his parents. He professed his love to the man he was love with, and he returned to college. I did not change his medications for his schizophrenia. That had nothing to do with this. 6 months later, I see him for a med visit, and I say, you're not calling anymore, suicidal anymore. What's going on? He said, well, I'm way too busy living to think about how to die. I've started making that part of my suicide prevention. Yeah, we can talk about whether you're better off dead or alive, but why don't we talk about how to make your life worth living and not so painful? So that isn't the question you keep asking. Building the strengths, building protective factors, building resilience is how you stay out of crises. Next slide, please. Our standard approach says safety first. Safety first, the way we're doing it, does not create safety first. I saw a study that showed that the time for the most risk of killing yourself was in the 2 weeks after you were discharged from a hospital. They had a rash of suicides from hospital discharges here at one of our local hospitals. So they did try to follow up, see what had happened. Let's see what the treaters in the community thought was going wrong. What happened? They found none of them had connected to anything in the community. None of them had any connections. None of them engaged with anything. Not only that, they couldn't hardly follow up on these people because there weren't even any phone numbers in these charts. There weren't any contacts. It was hardly anything. These people died because they had the #1 risk factor for suicide and violence, which is isolation. If you really want suicide first, do welcoming first. I went to a VA in Danville, Illinois. They were busy on doing safety first because the Congress was coming down on them for some deaths. They made the whole ward incredibly bleak and terrible and empty, removing anything that could possibly be used for suicide. So that now when a soldier came after being released and he's got PTSD and he barely comes in the hospital, he comes in there and it's all bleak and terrible and no life at all. And he said, I better just say I'm not suicidal and leave. And then they wouldn't show up to any other services after that for the rest of their lives. That's not how to make people safer. I asked them, how many people need that kind of safety first, that extreme measures in the first place out of your ward of 25 people? They said, well, 1 or 2. I said, so what if you do a one-on-one staff for those 1 or 2 and make everybody else have welcoming first and create a place that's full of life and engagement? Well, we don't have enough staff to do that one-on-one. So you have enough staff to do, the Congress says, remove everything and put in that rich because you got them unengaged and didn't connect them. Next slide, please. The first stage of recovery in a recovery model is hope and engagement, welcoming, not diagnosis. I had a student here just last week, comes in, the social worker with her did a whole suicide assessment because she told the medical doctor she was going to jump off the roof here. He decided, yeah, it's not that suicidal. And so I said, how Steve Mark maybe can help you. He's telling me this, we're seeing her together. And I said, wait a second, what's your name? Her name is Sally. Then where are you from? I'm from Kyoto. Oh, I've been to Kyoto. It's an interesting mix of these old things, the Zen rock gardens we're talking about, and these ultra modern buildings and the train station, all this stuff. We're talking about this stuff. When we finished like 45 minutes later, when the socialist told me, he says, wow, you got her to talk about way more stuff and reveal way more what's going on with her than I did. But that's because I started by talking about Kyoto and her life. I engaged her as a person first. He asked her at the end of the session, so how are you feeling now? He's still doing a suicide prevention. And she said, well, I'm hopeful now. And she was full of smiles. She came to me yesterday and got her first medication prescription, picking out which medication she wanted and thought would help her. And she tried to, for the first time, go over to the counseling center. Unfortunately, the counseling center doesn't have any appointments right now. So they said, all right, we'll do a suicide assessment. But that didn't actually help her. And now she's had to keep calling each day to get a counseling appointment. But she now has hope, she's engaged, she has a chance. Now you guys might say, well, that's an easy person. Come on, that's easy to engage. The people we see at our ER in a hospital and police, that's much harder. Next slide, please. Recovery has a lot of advanced recovery techniques for actually engaging with difficult people. Don't you dare not train any of your staff at these call centers and these outreach things in your crisis programs. Don't train them in any of these things and then say, we can't reach them, we have to be coercive. These things work if you know how to do them. If you actually train them, if you actually learn them, if you actually do these things, you value these things. These last two slides came from Kenneth Minkoff and I did for SAMPS, a thing called Recovery to Practice to teach psychiatrists about being more welcoming. Next slide. Crisis is a process. We only respond to the most dangerous time normally. There's things you can do on the way up to prevent it. There's things to do on the way down to stop it from happening again. There was a guy at Skid Row who said, why do they always give me those shots that make me all twisted all the time? I said, well, what do you tell them when you go? I say, oh, I'm hearing voices. I want to kill myself. But you don't hear voices, do you? No, but that's what you have to say when I'm fed up and want someplace to eat or a way to get out of the rain or a place to stay. People, and so then you get a medicine that you don't need for the wrong thing. If we say you have to have a crisis, be suicidal or dangerous to be here, that's what they'll be. When you make a crisis program, most of the crises are caused because of the gaping holes in the rest of the system, in all these other boxes. In Los Angeles, our biggest gaping holes are homelessness, having housing, accessible pills that you can actually walk in or get her in between appointments or drop in or stuff like that, and someone to help when you're really messed up and you're high or drunk along the way, especially on speed. So our local peer-run crisis program says, wait a minute, we don't do those things. When they made rules, don't send us someone who's homeless. This is just a respite program. We don't want to be stuck with putting someone on the street after this. We don't have a psychiatrist. You better come with 30 days worth of meds. And we can't handle big speed detoxes. You have to be 24 hours sober before doing that. They made their program run much better by making these rules. And they made the case managers who were referring people to them start referring them back to the emergency room instead. And the emergency room say, see, peer respite doesn't work. If you don't meet people's needs at whatever the gaping holes are, at whatever box it is, you're going to be irrelevant. They'll say recovery doesn't work. If you do start meeting needs, whatever your session's needs are, then you have a chance of spreading and reforming the whole system. Next slide.
Dr. Ragins, this is terrific. We've got about a minute left.
Okay, next one, pass this one. Keep the next one. Thanks for the update. And one more. This is what we gave to the Mental Health Service Act to say, this is ways to evaluate your crisis services. Look at this list and see, is this how we're evaluating our services? Is this what we're doing? Are we actually paying attention to the crisis going up and down, the context of the crisis? Did we just get about fear and dangerousness? Did we re-traumatize people? Did we have opportunities for growth? We deal with the underlying issues. Did we just re-stabilize them and setting them up for the next crisis? Did we impact their long-term recovery? Last slide. This is just a thank you and a goodbye and saying, if you thought that went way too fast and you're interested in more, I got 3 things out there for you. One is my new long book about a guidebook to psychosis. Bezos needs more money, so you can buy some on Amazon. I've got a website that's got over 100 articles written in the Village and a handful here at Cal State Long Beach about recovery on all kinds of stuff. And I can do various Zoom or in-person trainings of various kinds along the way. I'm still in that business. Thank you for the opportunity, David.
Dr. Ragins, wow, and thank you. I know that was super fast. And yet, just watching the chat and text, people are really resonating with your just your humanity that you're sharing. And look, the reflection for me is that the power of peer supports and the power of our psychiatry leadership, which is where these approaches rise or fall based upon risk management, quote unquote, versus a true recovery approach. We've got a couple of panelists to give us some thoughts. Craig Miller, you wrote a book, This Is How It Feels. Craig, are you with us to reflect on Dr. Ragins' presentation?
I am. Thank you, Dr. Reagan. Sincerely, you're a beautiful person. I'm deeply touched right now. You gotta give me a second here. I'm good at crying. So I'm an attempt survivor, lived experience, and through the years since I was 15 years old, I'm 45 now. I have one person that I remember, Dr. Reynolds, who treated me the way you're teaching people to treat other human beings. And that's the only person I remember. In fact, I wrote about him myself in my book, and I sought him out years later and made sure to connect with him for what he did for me. So the work you're doing is very, very, very significant. And I can tell you it is deeply appreciated. Someone put a comment, it'd be interesting to hear from you and someone who's been on the other side of it. And I can tell you I've been on the other side of it, and it is highly effective, highly effective. So I appreciate deeply what you're doing. If I can be real quick and just say from my perspective, I look at suicide prevention through the analogy of a war. And I know that's a brutal analogy, but I don't have a better one, because I think of it as three components. We have people who are on the front lines, who are actually fighting. And what that translates to is there's people trying to make it end. There's people trying to stop the war. And the second part is people dealing with casualties and recovery, and that's caring for the wounded, and we have that in suicide prevention. And then there's the messaging and the narrative and what we're doing to keep everyone aligned and focused. And I feel like there is a heavy weight on the recovery and caring for the wounded and the support, and there's not enough on the front lines. There's not enough people truly and I understand why. If you get into suicide prevention, it's usually because you've been affected by it in some way. So it takes a lot of compassion to get involved. And that's usually our entryway. In order to be on the front lines, you almost have to walk past the wounded and keep moving and go into the front and work on making everything end. And that, I think, needs more attention. And this is exactly what this is. This is the front line. This is doing boots on the ground, trying to make the war end. And this is absolutely beautiful to me. So I applaud you and everyone else who's part of this. Thank you.
Wow, Craig, so heartfelt. I so appreciate it. And it just reminds me, Craig, as you're telling your own story, not only your book, but also you were featured in the S Word documentary, which was so powerful about your story. So we also, Mary Jill Alberti, you also recommended and connected us with Casey Moyer with the Mental Health Association of Nebraska. Casey, are you with us to give a reflection? Karen, do you know if Casey is with us?
I don't see her online right now.
Okay. So Dr. Ragins, thank you so much. Craig, appreciate your, wow, what a power. That analogy is going to go with me, Craig. Thank you so much. Karen, let's go to the next slide. And again, Dr. Reagan's book is pretty powerful synopsis of his work over 30 plus years, being very much on the front line. For those of us who say that's these are notions, these are not notions. He was doing that in that Villages building that I shared up front with a population of individuals with the life challenges that were very significant. So the most significant that you can conceive of. Stephanie, we've got a dear friend and mentor of mine, Greg Graham, was our crisis talk interview for this week.
Yep. So he's the founding partner of Behavioral Health Link, which operates GCAL on behalf of the Georgia Department of Behavioral Health and Developmental Disabilities and Beacon Health Options. BHL also, are you able to hear me? For some reason, it just—
No, you sound fine, Steph.
Okay.
Go ahead.
Oh, good. Okay. BHL also answers Lifeline 988 calls in Georgia. And Greg shared with me his experience with his son, Monty, not just navigating the behavioral health system, but school and criminal justice, and how with his son growing up, the experience was primarily punitive, not restorative. And so a lot of Dr. Reagan's points today really resonate with my conversation with Greg. He also shared that there's a vital moment that can change the trajectory of a person living with a substance use disorder. And that's when the desire for change and access to care intersects. And that really impacted how Greg developed BHL. And if he's on the line, Greg, if you can talk a little bit about your personal experience with Monty and how this shaped how you developed BHL, and how important it was for you to create these very quick, rapid connections for people in need.
And Steph, we definitely
Yeah.
want folks to read the article. Greg, if you could just make a quick comment. I didn't know if you'd be willing to talk this intimately and personally with Steph, and you did. Can you talk about your decision to talk about your life and Monty?
Well, actually, I felt like I could compartmentalize some of the other aspects of my life. I mean, I worked 50 years in the mental health field. For a while, I was a licensed clinician, decided to get into administration and all that. So it all runs parallel to our experience with Monty. And it was a very difficult decision, actually, to talk about it, because normally I don't do that. And but it was a good conversation, and so I'm glad I did. And I think the thing that I wanted to convey, I mean, there's so many things that I would talk about and get into war stories or something like that. That's not appropriate or that helpful. But just, I was already interested in helping people get connected to services better. I had wonderful experiences. In my first 13 years, I worked in community mental health, and I worked in 2 mental health centers that were just great and very creative and very innovative. I like to try to do innovative things. And it sort of laid a foundation crisis services, because I ran the crisis services in one of the mental health centers. So a lot of the stuff we're doing today has been done somewhere by someone years ago. So it's a process. But, I mainly have wanted to professionally try to, take some of the lessons and observations about helping folks get into services and supports. It doesn't have to be services, clinical services. A lot of times a person just needs support, and sort of most of the rest will take care of itself, the de-escalation, everything else. If it's freezing cold and it's an ice storm in Atlanta, and I need a place to stay and I can't get into a shelter, getting a place to stay that's safe is critically important. So just trying to have those connections and have that be available all the time, 24/7. And one of the things that I realized, or I felt was true, and it's still true in some cases. Crisis services tend to be very disorganized. There's a focus on, defaulting to the most intrusive and restrictive kind of law enforcement approach, when some other approaches could work much better, sooner. Crisis services sometimes, historically, when we started, no one kept track of really much of anything about crisis services. Go out on a crisis call, there was very little data taken, that kind of thing. So my goal there has always been to help services be available, be fitted to what the person really needs from their point of view, to be immediate and to be connected in the process, because you can take crisis, as we know, there's a whole little continuum of care on the very front end of accessing services that can be broken down, and the handoff has to be made. And I've always been real interested in that whole aspect. So I probably strayed pretty far from what you were trying to ask me, but
No, Greg, that's terrific. Thank you so much. And thank you I hope everyone will read this week's interview. Stephanie, I love the way that you told the story, and Greg and Harriet for sharing. So thank you so much.
you're welcome.
Let's go to SAMHSA. And Richard, are you giving the update for SAMHSA today?
Hi there, David. Be glad to, and I think John Palmieri is also on the call. I'll just mention a couple of things. One is that Starting this week, we have a new member of our 988 team. He's very familiar to people who are active in suicide prevention and in crisis services. And James Wright has returned to SAMHSA. He has been chief of staff at the Veterans Crisis Line, and before that was a member of the suicide prevention branch. And James has a very deep and broad knowledge of crisis systems from his work at VA, his work at SAMHSA, and his work before that in Austin in overseeing a crisis service. So SAMHSA continues to be all 988 all the time. I'll just mention a couple of other things. Last week, and I might have mentioned this last Wednesday, but last week we did a briefing for Secretary Becerra on 988, who is extremely interested in this work. We're very grateful for the HHS support of the work that we are doing. We actually have another briefing with Secretary Becerra next week, which will be on the work of the Behavioral Health Coordinating Committee. And half of that will be devoted to the Suicide Prevention and Crisis Care Committee. So those are just a couple of things that I have, and I think John is on. John, are the things, if you are on, are the things you would want to add?
Thanks, Richard. And I think the most exciting news was the addition of James to the team. So I'm glad that you mentioned that. Really excited to have him on board. He will be working with Richard and the Vibrant team very closely on sort of the operations piece of our work plan, and really kind of focused in on readiness of the system to respond to calls, chats, and texts with 988 implementation. We'll be working with Vibrant as well, and Richard and the team on looking at their preliminary state planning grant data, which hopefully will help inform sort of readiness tools and other technical assistance activities, which could support states and local centers with respect to 988 implementation. And then at the federal level, we're engaged in lots of ongoing coordination and briefings, as Richard said, with the secretary, who's quite engaged with our work. A lot of back and forth with respect to appropriations for FY23, and then really looking at increased opportunities to collaborate across federal agencies, including Department of Justice, with the Office of the National Coordinator for Health Information Technology. Again, looking at opportunities for intersectionality in the work that we do, in ways that we can leverage resources within the federal government to really support the work in advancing our work plan.
And I would just add to that, and thank you for that, John. I would just add that we've also met and have ongoing dialogue with the Office of Emergency Medical Services in the Department of Transportation, because a critical part of 988 moving forward will be the 988 and 911 coordination. So we're making a concerted effort to be talking to partners in the 911 space to deepen our knowledge and interactions with those in that space as we move toward July 2022, because we know that's going to be a critical piece of the success of 988, is the extent to which 988 and 911 are collaborating in an effective way.
Terrific. Thank you, John. Thank you, Richard. Brian, update from the States.
Yeah, thank you, David. I'm not going to say very much today. I think it's been a very emotional hour. I thanks SAMHSA, Richard, John, thank you, David, and our speakers. It's been very, very emotional, very compelling to hear the stories, and I guess also to understand that we have hope and we can make a difference. And so with that, I want to emphasize to people on the call, one of the concerns we all have is people in healthcare getting burned out. This has been a really tough 18 months dealing with COVID, as well as the usual problems of people with behavioral health issues. Having COVID on top of it has been very, very difficult. So the message, I think we have to take care of ourselves. We have to go to Disney World sometimes to relax and to get our lives back together. This is very difficult work. So please, for the people on the phone, take care of yourself. Indulge in self-help. We have a problem because we are losing workforce. We have to make it so that our field takes care of each other and that we're making our work environment safe for others who would be able to join us. We have a marathon in front of us with 988 and crisis services. All the states are focused on 988 and crisis services. It's a huge task. We're going to need a lot of people to help us. We need to make sure that it's safe, the environment is safe for ourselves and also attractive to others. So with that, let me pass it back to David, but please take care of yourself. Go to Disney World. Wow,
Brian, what a wonderful message. Just the thread that you're pulling through today. I'm just sad. We heard this announcement the last few days that Squid Game is the #1 Netflix show in 90 countries. And it reflects this just pervasive feeling around the world of people feeling left behind, of feeling this competitive, cutthroat environment, and this hopeful, supportive message that you're talking about, that Greg was keying in on, that John Draper was talking about, and what we're looking for in the staffing. Just love that, Brian. So let's go to today's Crisis Trivia Hot Seat. And last week we had Dale Adair, thanks for jumping in, and Jack Roselle called it. And the point of last week's Trivia Hot Seat was we don't really control fully the promotion and public awareness of this number. So 988 is not that well known yet, but we had Logic and his Grammy nominated song, as well as Dale was not wrong about the events that also drove attention. But today we've got a different Crisis Trivia Hot Seat. And Megan, do we have a participant for today's Crisis Trivia?
Victor Armstrong.
Vic. So Vic, you were the facilitator last week. This week you're in the hot seat, Vic. So I'm going to go old school for a moment here. Vic, 988, this number was a little bit of a shock to those of us in the field, because after Congress asked for a 3-digit hotline, the early conversations really centered on 611 and 211. And the commissioner and the FCC came out with 988. And we were like, what? And just in hindsight, what a brilliant move of 911 and 988 being potentially our two most important numbers in all of America. But let's go back. The Lifeline number, Karen, if we can go one more build. The Lifeline 1-800-273-TALK, just like 988. We were expecting 611 or 211 or something else, and 988. 1-800-273-TALK. Tell us what was the origin of that 1-800-273-TALK number in late 2004? There's a similar sort of story. Phone a friend, ask the audience, or Vic, you know the answer to this question.
I do not know the answer. I don't think buying a vowel is going to help me.
So you can't buy a vowel. Let me also clarify, SAMHSA and Vibrant, of course, know the answer. So you can reach out to the audience or phone a friend that is not SAMHSA or Vibrant.
Oh, I was going to call John Draper.
Yeah, but nice try, Vic.
Let me ask the audience.
Okay, audience, what was the origin? Where did 273-TALK come from in late 2004? There's crickets from the audience so far. Megan says there was 1-800-SUICIDE and they wanted something more positive. That's the only answer that's shown up so far. We'll give it another second. It was a number North Carolina had, David Westbrook. I will give you a hint that neither Megan or David are right and neither are wrong. They're both in the ballpark, but neither one has it quite right.
Okay. So I'm gonna guess that it would not have been North Carolina. Yeah, I'm gonna guess it was a different state. But I am gonna say it was a number that already existed in a state that had more of a positive connotation than what was being used, and so that was the origin of the number.
So, I'm going to look to Richard to decide whether, so Richard is the only person who's gotten a credit. He got half credit on a Crisis Trivia Hot Seat. No one has nailed one yet. Richard, are we going to give Vic half credit, full credit, or no credit? I'm leaning toward half, but you may have a different view. And Karen, if you can bring up, it does relate to 1-800-SUICIDE, which was the National Suicide Prevention Lifeline at the time. And the number, yes, we did land up coming up with something more positive, but that's actually not the truth, or not the full story. Richard, what's the determination on points here, and fill us in on a little bit of the brief story, Richard?
Well, I think that both Vic and also David Westbrook should get partial credit, maybe a quarter credit or half a credit. SAMHSA's funding opportunity announcement for the national hotline system going back in 2004 did specifically request the use of a positive life affirming number, was the framing that was in that notice of award. So that, that was quite accurate. But where the number 1-800-273-TALK actually came from was not North Carolina. It was from the local SENT hotline in Charleston, South Carolina, and that they had access to that number, and that got switched over to become the number for the National Suicide Prevention Lifeline. So that is the story.
Great. Thank you, Richard. Thank you, Vic. We've got another partial credit here. We're still awaiting the first full credit Crisis Trivia. So that mantle is still out there for someone to grab. Let's go to the next slide. Sarah, do you want to give us just a quick comment on where you think reconciliation is going?
Yeah, absolutely. Not a huge update from last week. We are still waiting to see what a top line number might look like, and if there is agreement on some of the drug pricing provisions as well. We haven't seen anything come out of the Senate yet, but there is also one more opportunity to provide comment to the Senate. Senators Cassidy of Louisiana and Murphy of Connecticut have released yet another RFI. So if you're getting your letters ready, that's another one I'll drop into the chat that you can provide some input on a future mental health package. But right now, anybody's guess on when/if they will come to agreement on reconciliation between House, Senate, and White House. Still ongoing negotiations, but hopefully they'll come to agreement on a top line number at some point soon, and then we'll be able to see what might actually get over the finish line there.
Terrific. Great. Thank you, Sarah. Natalie and/or Taylor, any comment from AFSP today?
I don't have anything additional to add today, and thanks, Sarah, for flagging the Cassidy Murphy response for us all.
Oh, terrific. Great. All right, let's go to the next slide. Actually, one more, Karen. So we do have an updated state laws map. And I believe, do we have Hannah from NAMI giving us the update today?
Yes, I'm here. Thank you so much. Very brief update. As you know, states are mostly out of session now, although many are gearing up for next year. Just briefly, since we last gave an update, Michigan introduced a pair of bills. One deals with 988 policy provisions and the other addresses 988 fee components. So HB 5353 designates the Michigan Crisis and Access Line as the state's 988 hotline center. It provides operational technology and data reporting requirements and describes coordination and payment for mobile crisis teams and crisis stabilization. And then its partner bill 5354 establishes a 911 fee on phone bills and defines what those can be used for. The state set a fee of 55 cents specifically. So these are now with the Health Policy Committee, and we will see what happens with them. We know that a bill is being drafted in Florida to really study financing mechanisms similar to Texas. New Jersey's bill is still active. Advocates are looking to push the bill during the lame duck session, which starts in November. So things are happening, and we'll continue to keep track of it. And hopefully this provides a little bit of context, this chart, and we'll continue to keep it updated for you all.
Hannah, we have just a minute could you reference the new call that NAMI is leading related to 988?
Yes, so this is a number of organizations that are active in state legislation are doing a monthly advocate call. It is the first Monday of every month at 4 p.m. I will drop the link to sign up if you'd like to be part of that call. I'll put that in the chat, but just provide updates from advocates around the country on what's happening, how to get engaged, and discuss similar challenges related to state legislation. So I'll drop that link in the chat right now. Thank you.
Wonderful. And Hannah, we will have a featured presentation from you and Steph coming up, but give us just 10 seconds on the Reimagine Week of Action.
Sure. Save the date for the week of November 15th. A number of partner organizations, I think there are 14 organizations joining NAMI now in leading this week of action. We'll have events discussing the intersection of crisis with different communities, talk about what 988 and crisis services really mean. So introductory for those less familiar. And we'll also have an advocacy intensive for state leaders who are leading advocacy efforts to really dig in deep and learn more about how they can be successful. And we'll be mobilizing advocates throughout the week. Really, the goal is to build awareness and notice around this issue and really build momentum at both the federal level and with state legislative sessions coming up. So we intend to release the registration site later this week or early next week, and we will make sure that that's available for you all. And we hope you can join us.
Terrific, terrific, Hannah. And Hannah, in that featured presentation, we've had some wonderful lived experience, lived expertise, perspectives today and in a number of sessions. Let's make sure, to the extent that we don't overpack your 15 minutes, but that family perspective that NAMI is such an ally for, let's make sure we get that into the mix.
Absolutely.
To crisis care. So thank you so much, Hannah. And look, we're going to go to the next two slides. Thanks to Stephanie Woodard and also the team in Washington State, Representative Tina Orwell, Jen Stuber, and others who helped us with these. These are our baseball cards, the stat cards for states that have already done legislation. We'll see Nevada come up next. But back in that NAMI slide, we saw 6 states that already have passed either meaningful legislation with a fee or without a fee. And it is our intention to do stat cards on all of those states. So if you haven't been outreach from us already, expect that outreach here coming up. We do want to start to accelerate bringing visibility to the other really great work that has already been done in the states that are moving this forward. And as we have others cross that finish line, hopefully over the course of time, we'll have 50 of these cards talking about the work to power and fuel this effort. Next slide. Do we have Hallie with us today to give just a quick comment on the Taking the Call Justice Center, a national conference on October 20th? Hallie, are you with us? I would encourage you to check out the Justice Center Council of State Governments Taking the Call. And Karen, if we can drop a link to that into the chat so that folks can check that out. And we've got October 20th coming up. So that looks like that will be this coming week. So we'll try to get that information out. And finally, our pipeline for these coming weeks, Dr. Sandy Schneider, who's been such a key partner and former president of the American College of Emergency Physicians, is going to talk about the current state of COVID's 4th wave challenges in hospital EDs. And it's really some striking conversations, as well as some really other amazing presentations we would expect with us taking the Thanksgiving holiday weekend off. So again, I'm with Brian. Thanks so much to everyone for the positive, hopeful message today, and all of you who contributed, Richard, John, Brian, Megan, and everyone who took part today. Thank you, and we hope you'll join us next week. Bye-bye.